Hi, now we're in week 3 and we are looking at anxiety and associated disorders. And we're going to begin with anxiety disorders in specific. Now again, I have to remind you, no self-diagnosis or diagnosing other people. We're not qualified to do so. Alright, it's not unusual that we might experience some of these things because in some respects, anxiety, which is a generalized sense of apprehension or fear, and it's normal, but it can become abnormal when it's excessive or inappropriate. Anxiety may be experienced with a large range of physical features, cognitions, and behaviors. And so there's a range. Remember, this is being looked at dimensionally by DSM-5, which would suggest there being a range. Normal, at risk, abnormal. And so there is a range. Some physical features will include jumpiness, jitteriness, increased perspiration and heart rate, shortness of breath, dizziness, nausea. Now, the sort of behavioral features associated with anxiety will include a need to escape or avoid situations, agitation, clinginess, and the need for reassurance. And then cognitive features, and remember, cognitive means thinking. So the cognitive features will include excessive or prolonged worrying, so naggingness in the mind about what might be and what might not be, overly aware of bodily sensations, temperature, heart rate, agitation, stomach upheavals, and jumbled thoughts and nagging thoughts. Now, we all have elements of this at times in our day, in our week, in our month, in our year. And it's not that we do have these periodically, it's the excessiveness, it's the sustained, prolonged, and you can't stop it. It doesn't slow down. It continues and increases over a period of time of weeks, even months. Now, most of us will experience it certainly from time to time when we've left something to the last minute and we have some anxiety around whether or not we can get it done. That's not the same in terms of an anxiety disorder as somebody who wakes up with this or stays up at night with these thoughts, or it carries on throughout the day and interferes. Remember the 6 things from chapter 1 that makes up what is normal and abnormal. All of those things get encompassed for a person with this condition. Okay? So what we're going to look at in the first video will be types of anxiety and associated disorders. And then in week 4, we're going to look at classification, if you will, the theoretical view, and then we're going to look at treatment. Okay? So I'm going to try and divide up most chapters related to different psychological disorders in that manner. Types, theoretical view, and treatment. So there'll be probably be about 3 videos per week unless I've divided a chapter in 2. All right? So let's carry on with this. We're going to look at types of anxiety disorders. Anxiety is a general state of apprehension or foreboding, and this disorder involving anxiety has historically been classified as neurosis, which was originally believed to be an organic type of disorder in its nature. The psychodynamic theory posited that the origins of neurosis lay in the psychological factors, that neurosis reflected a threat to the conscious emergence of repressed, unacceptable impulses. Freud believed that the different kinds of neurosis reflected the different ways in which the ego defended itself from anxiety. This historically based hypothesis united the current anxiety, dissociative, and somatoform disorders as neurosis. Now, neurosis hasn't been used by the DSM since 1980, and instead they consider observable behavior to explain anxiety rather than causation assumptions. DSM-5 considers dimensions of disorders: anxiety disorder, panic disorder, specific phobia, social anxiety disorder, and generalized disorder. Now, Anxiety disorder, anxiety disorder itself can be adaptive. It can be useful, helpful, when it prompts us to seek medical attention or to study for an upcoming test or avoid a dangerous situation. This is considered useful or adaptive anxiety. It becomes maladaptive or unhealthy or risky when the level of anxiety is out of proportion to the level of threat, or it occurs when out of the blue, and it's not a response to the environmental change. It just seems to emerge into the brain. Now, panic disorder is a form of anxiety disorder and is characterized by repeated panic attacks. Now, these involve physical features, and most notably cardiovascular symptoms such as pounding heart rate, respiration, shortness of breath, heavy perspiration, dizziness, and weakness, which may be accompanied by sheer terror, fears of losing control, losing one's mind, even fears of dying. Now, panic disorder refers to the reoccurring unexpected attacks. This is in criterion A. Now, this you're going to see if you check. Let me see if I can put it up here. If you check, I've forgotten what page it is, but I think I've got it posted here in a minute. A panic attack is an abrupt surge of intense fear or intense discomfort that reaches a peak within minutes, and during which time four or more of a list of 13 physical cognitive symptoms will occur, and this is also in your textbook. The worries about panic attacks and their consequences are usually pertain to certain concerns, such as the worry that a panic attack reflects the presence of life-threatening illnesses. There's social concerns, such as the embarrassment or fear of being judged by others negatively. Because of visible panic attack symptoms, the concerns about mental functioning, such as I'm going crazy or losing control, and these fit within criterion B. Panic disorder is also often comorbid. This means occurs at the same time with another disorder, namely agoraphobia. Agoraphobia, there it is there. It's about 2% prevalence in. Now, what you're seeing at the bottom left hand there, table 3.2 and table 3.3, this is on page 102 and 103, and this is the criteria for panic disorder and agoraphobia from the DSM-5 criteria. When I was mentioning about criteria A and criteria B, that's what I was referring to. Now, agoraphobia, about 1/3 to about 1/2 of the people with panic disorder also have agoraphobia, which is and the majority of people with agoraphobia have a history of panic attacks. Panic attack sufferers often limit their fear, are often limited about going outside actively in fear of recurring attacks, and this can lead to agoraphobia, the fear of venturing out into public spaces. Now, in the new DSM-5, agoraphobia is a distinct disorder involving fear or concern, anticipatory anxiety, or excessive worry about being in open spaces, being in closed spaces, using public transportation, standing in line, being in crowds, and in general, any place outside the home environment. Agoraphobia is diagnosed separately from panic disorder. If both exist, 2 diagnoses are given. About 1/3 to 1/2 of people with panic disorder also have agoraphobia. The majority of people with agoraphobia have a history of panic attacks. Now, we're going to move away from panic attacks and agoraphobia and into generalized anxiety disorder, also known as GAD. Generalized anxiety disorder, you'll find the table 3.4 on page 105 that looks at the criteria that's required for that type of diagnosis. Now, generalized anxiety disorder involves persistent anxiety that seems to be free-floating. This type of anxiety disorder is characterized by general feelings of dread, foreboding, and a heightened state of sympathetic arousal. So in this instance, your sense of worry is overwhelming. When it talks about it being foreboding or dread, it's not just a short term or a momentary, fleeting moment. It is persistent, and it is carried over time, and it's you have to remember it interferes with the normal active engagement in life. It remember looking at the conditions in chapter 1 about what makes the difference between abnormal and normal. All of the conditions that we talk about are on a scale which interfere with people's normal living as lives and are not culturally normative. So although many of us might experience some things that we might say are anxiety based, if they're not meeting those criteria, then they're not diagnosable. And again, I repeat, don't self-diagnose. Now, anxiety disorders include something that is very much more common that we would understand and we've heard of before, and these would be the phobic disorders. Now, in phobias, there's an excessive, irrational fear of a specific object or situation. Now, phobias involve 3 points: the behavioral component, physical and cognitive features. So, the behavioral component is avoidance of the phobic stimulus. The physical would be the kind of anxiety-based physical experiences that you would have, and the cognitive would be the self-talk that you would have regarding that situation or that object. So if we were to look at, the specific phobias, and with specific phobias, they're excessive fears of particular objects or particular situations, such as mice, spiders, tight spaces, or heights. Now, you'll find these also in your textbook on page 108, 3.6. Now, in this instance, there are 5 diagnostic subtypes. And in all of these, you have animal type, you've got natural environment, blood injection, injury type, situational type, and other types of phobias, choking or contracting an illness. Now, in these, when you think about the 3 sort of features of physical, behavioral, and cognitive, physical features can include jumpiness, jitteriness, increased perspiration, heart rate, shortness of breath, dizzy, and nausea. Now, these are all sounding like what I initiated this video on, and in fact, that's part of what makes anxiety so significantly debilitating, is that it has an impact of physical features. The behavioral include this need to escape and avoid the situation. Anyone who has a fear of spiders, dogs, mice, aren't sticking around when they see them. They back away and avoid that situation at all costs. They're agitated. They have a sense of clinginess or need of reassurance that everything's going to be okay. The cognitive features about prolonged worrying and excessive worrying, overly aware of body sensations and the sensation of being anxious, jumbly thoughts, and nagging thoughts. Now, with the shift from the DSM-4 to the DSM-5, there have been other categorizing or labeling changes. One example of that is social anxiety disorder. It was often described as social phobia in the past. Now, when we look at some of the conditions, if you will, that some social apprehension is normal in life. Perhaps getting nervous for a job interview, a presentation, or other social or public situation is normal. But however, extreme form of this common fear is known as social anxiety disorder. Social anxiety disorder involves intense fear of being judged negatively by others. Now, it's important to note, again, we all might have some anxiety about standing in front of people, but we could persevere through it, and although we'd be nervous and anxious, it doesn't affect us in such a dramatic and negative way that it is so intensely fearful, that it will affect the quality of our lives. We'll make decisions that negatively affect us. In spite of how much we know they're going to negatively affect us, we will pursue that anyway. It's a very common, in terms of phobias, it's common. About up to 15% will experience it at some point in their lives. Now, one that often, and I've heard this a lot myself, in conversations, that people will describe, their complexity or their tendency towards this next psychological disorder in terms of anxiety disorders, and that is that of obsessive compulsive. People will often say that it's not just my OCD. Well, if you watch the video that I've posted for the journal, you'll see some description about how it's not something that you can just offhandedly comment about and sort of make light of the notion that, oh, well, it's just my OCD. Unless you've been diagnosed, you're not obsessive compulsive. That you happen to like patterns or that you happen to like things in certain order is not obsessive compulsive. What makes it different is that there's a cycle about it. And a part of this is anxiety riddled. There's some common obsessions. There's obsessions which, well, obsessive compulsive disorder involves reoccurrent patterns of obsessions, compulsions, or the combination of the two. Obsessions are intrusive, unwanted, nagging, persistent thoughts or images or urges that create anxiety and seem beyond the person's ability to control. Now, as much as I like my desk to be in order, it's not something that is a nagging, unwanted, and intrusive, and it doesn't create anxiety when it's not to the degree, that it seems beyond my control, that if I have an important meeting to go to, I can still go to that meeting in spite of my desk not being tidy. I might prefer my desk to be tidy, but it's not going to interfere with my ability to do my job. Now, the compulsions are repetitive behaviors or mental acts that a person feels compelled or driven to perform, such as repeated elaborate washing after the bathroom use, or cleaning up because of the fear and compulsive obsession about germs. Now, the difference here, of course, is that this is excessive. It's compelling. It's not like you could choose. Most of us can choose. And that's what makes some of these disorders so much more complicated and misunderstood than somebody who might say, it's just my obsessive compulsive creeping in. That's why I'm doing this thing repetitively. It's not the same thing. And in fact, it's belittling, if you will, and minimizing the overall impact that it has on a person's life who does experience it to the degree that they do. Now, in table 3.7 in your textbook, you'll see these examples of obsessive thought patterns and compulsive behaviors. And I've met people, because of the work that I've done as a counselor, who have had bleeding hands because of excessive washing and cracking of fingers, who have had serious effects on their life because of an obsession and a compulsion. One woman that I worked with would frequently stop her car when she was driving because she thought she hit somebody, and she'd have to get out of her car and check underneath it every single time. We drove from one location to the next, which was less than 10 minutes, and we stopped 17 times. Now, that's obsessive compulsive behavior. Often we don't have that degree of compulsion to do the things that we end up doing, and feeling we have no control, that if we don't get out of the car and check underneath it, that the anxiety that it produces is so great that it debilitates the rest of our ability to do anything. Now, if we carry on with more trauma and stressor-related disorders, one of the first that comes up is that which is known as adjustment disorders. Adjustment disorders are among the mildest of psychological disorders. Now, you'll see below where you'll see the DSM-5 criteria. An adjustment disorder is a maladaptive reaction to an identified stressor that develops within the few months of the onset of the stressor. A maladaptive reaction is characterized by a significant impairment in social or occupational or academic functioning, or by a state of emotional distress that exceeded those normally induced by the stressor. A breakup of a marriage, a difficult time through an academic environment. Normally we handle it, but in adjustment disorder, it becomes something that is overwhelming and is characterized by this impairment. It affects the way we're able to carry out our life. The reaction may be resolved if the stressor is removed or the individual learns to adapt in a more successful way. Now, in a more severe case of trauma stressor-related disorders, we look at one that's related to what will follow, and this one here is ASD, or acute stress disorder. In acute stress disorder, and it's related to PTSD, or posttraumatic stress disorder, people develop stress reactions that follow exposure to traumatic events, things involving combat or exposure to natural or technological disasters. It involves a disassociation or a feeling of detachment from oneself. When one is associated, you feel connected to yourself, and disassociated means you almost see yourself outside of yourself. You don't feel connected. And of course, that's not healthy. An acute stress disorder occurs in the days and weeks following the exposure to the traumatic event. And so in these instances, you have this traumatic experience, and it may not occur right away, but it starts to occur shortly in relative terms, shortly after that event, and your inability to sort of manage life in a particularly positive way in this greater disassociation. Now, the post-traumatic stress disorder, people develop the stress reactions that follow the traumatic events, but it persists for months, even years, even decades after the traumatic experience. It may not begin until months or even years after the event occurs. So it's more severe, it's longer lasting. The features of a traumatic stress reactions: extreme anxiety or disassociation, so feeling detached from yourself or from your environment. Intrusive memories and flashbacks. You know, military people coming back from war, their flashbacks might represent as walking down a street and a car backfires and they hit the ground as if that sound replicated a sound of a bomb going down near them. So that would be more of a flashback. Or heightened sense of arousal or vigilance. As you're doing your work, somebody taps your shoulder, a hyper sense of vigilance for somebody who's been through a traumatic experience would be an overreaction to that touch on the shoulder. And difficulty concentrating. Now, there was a popular book that was out based on the life of a I'm sorry, I'm just losing his title, Romeo Dallaire. He was involved in a peacekeeping responsibility in Rwanda back in 2000, and his experience was captured in a book that he wrote. And he suffered from PTSD, and in the year 2000 attempted suicide by combining alcohol with his antidepressant medications. He talks about his experience and what it was like in terms of that traumatic experience of seeing over 800,000 to 1 million Tutsis slaughtered, and being there, having nothing that he could do, and that he was there as a peacekeeper, and how it affected his life years and decades later. So this has been video part 1, looking at the different types of anxiety and stress-related disorders. And next week we'll look at the theoretical perspectives and how the different theorists look at these disorders to explain them and perhaps understand them. And then the second video I'll post next week will look at treatment and what sort of strategies will some of these theoretical groups propose to support people better. All right. Here we go. Week 3, we're moving right along. Good luck, everybody.